الله الرحمن الرحيم. اسمحوا لي النهارده ان انا اكون ضيف على حضراتكم to discuss updating the management of spinal tuberculosis or tuberculous infection of the spine. انا اسمي رافت كمال، انا استاذ جراحة العظام وجراحة العمود الفقري ورئيس وحدة جراحة العمود الفقري في قسم جراحة العظام كلية طب جامعة اسكندرية. أنا هبدأ الأول كيس برزنتيشن. يمكن الكيس برزنتيشن دي مهمة جدا، حالة بنشوفها كتير في العيادات عندنا. ده 24 years old patient who presented with multiple cystic swellings in his back opposite the dorsal and the lumbar spine. زي ما انتم شايفين cystic swellings، لكن there is no there is complete absence of the cardinal signs of manifestation، يعني of infection، زي مثلا الهوتنس او الريدنس، كل ده مش موجود خالص. ده another presentation of the swelling. We can see the swelling and can see that swelling here is present opposite the dorsal spine. Another swelling with the patient is bending forward. We can see here that the swelling is extensive. On MRI, we can see here in the MRI that the swelling is a cystic swelling, large swelling, abscess, causing complete destruction of the vertebral body and encroaching on the neural element. And another MRI section, here we can see that the MRI section is showing the destruction of the vertebral body and the again another section showing the cystic swelling, the large cystic swelling. So the diagnosis usually is that this is a Pott's disease of the spine, or what we call the tuberculous spondylitis with cold abscess. Actually, in the current decade, the incidence of tuberculous infection of the spine is increasing again. This increase is mainly due to the immunocompromise, that is the disturbed immunity of the patients. So if we return to the story from the start, the first we start is the epidemiology. The epidemiology tells us of tuberculosis that the bone and joint involvement develops in about 10% of the patients with tuberculosis, and that spinal tuberculosis accounts for 50% of the patients with bony tuberculosis. This means that the spinal tuberculosis or the tuberculous infection of the spine is one of the common sites for the tuberculous affection of the skeleton. Also, the neurological deficit of paraplegia, which occurs in 10 to 45% of spinal tuberculosis. This means that there is another or added problem, which is the neurological deficit. This neurological deficit could be in the form of paraplegia or paraparesis, or if the tuberculosis is affecting the cervical spine, it could be in the form of quadriplegia or quadriparesis. This slide actually shows the incidence of the tuberculous infection of the spine according to the site. So according to the site, the commonest site, as we can see, is in the dorso-lumbar spine, and there is another site which is the mid-lumbar spine, which comes next in frequency. This is very important to consider if we return to the anatomical fact that the spinal canal diameter is smallest in the area of the dorso-lumbar spine, which means a higher incidence of neurological deficit associated with the tuberculous infection of the dorso-lumbar spine. Okay, so etiologically, if we return to etiological spinal tuberculosis, it is always secondary, because we know very well from the epidemiology of tuberculosis that the primary tuberculosis has certain sites. The most common site of primary tuberculosis is the pulmonary tuberculosis, but in spinal tuberculosis, this tuberculosis is always secondary. And usually it spreads from well-established tuberculous focus, as we will see soon. Sometimes there are many reports from the rare occurrence of spinal tuberculosis from the direct spread from the visceral tuberculosis. So if we have a visceral focus of tuberculosis, as in the colon or in the intestine, the spinal tuberculosis can occur from direct spread of the tuberculous infection from the viscera directly to the spine. Okay, so what about the primary focus in tuberculosis? Where tuberculosis starts, the tuberculous infection starts in the spine. We have actually 3 sites. The first site is what we call the peridiscal. Here the infection occurs very close to the intervertebral disc, affecting the end plates of the vertebra above and below. The second is the central, where the tuberculous infection starts in the center of the body of the vertebra. And this is a typical form of tuberculosis. The third is what we call the anterior part, or what we call the subperiosteal focus. Here the infection occurs from a focus, spreads from a focus which is present in the anterior part under the periosteum. But actually the statistics will tell us something very different, which is that 52% of the tuberculous patients of the spine tuberculosis, by presentation or at the time of presentation, the tuberculosis is too spread in the spine that it is very difficult to determine whether the primary focus is peridiscal or central, or it is anterior or subperiosteal. Also, 2% of the spinal tuberculosis are atypical. And by atypical tuberculosis, we mean the tuberculosis which affects the neural arch. Neural arch means the spinous process or the lamina. This is very rare. And sometimes there are very, very rare reports, case reports, about the presence of granuloma in the spinal canal, but without any bony involvement. So we have tuberculous granuloma, the classical tuberculous granuloma or tubercle, which is present in the spinal canal, causing spinal canal stenosis, but without any bony involvement. And as we said, this is very rare. Here in this spine, in this specimen, we can see the spine, and we can see the spread of the tuberculous infection from a peridiscal tuberculous focus. And the classical pathology in tuberculosis, as we know, is progressive destruction of the structures, whether the cartilage or the soft tissues or the bones, and replacement of the destroyed tissue by tuberculous granulation tissue, which undergoes later on caseative necrosis, giving rise to the caseous material, which collectively we call it the cold abscess. And here we can see the destruction in this specimen of the bone by tuberculosis. And here again in this specimen we can see the tuberculous granulation tissue, and this tuberculous granulation tissue is compressing the neural elements, which with the presence of what we call the tuberculous deformity or kyphosis or gibbous. And the tuberculous gibbous or deformity or kyphosis can reach to a very severe deformity, as we can see in this specimen. Of course, this type of deformities are very rarely seen nowadays because of the advent in the techniques of spinal surgery, as we'll see shortly. So, what are the goals of the management of spinal tuberculosis? The goals of the management of spinal tuberculosis are first, the eradication of the infection. This is the first goal and most important goal. The second is the management of any neurological deficit if present. And the third is the prevention or the management of the deformity if it's present. So the goals of management of spinal tuberculosis are either the eradication of the infection, management of neurological deficit if present, and the prevention and the management of the deformity. Okay, what about the challenges? Is it challenging to treat spinal tuberculosis nowadays? Yes, it is. Why? Because first of all, we have to remember that we are treating an immunocompromised patient, because if the immunity of this patient is normal, this patient wouldn't have developed the tuberculous infection of the spine from the start. And by immunocompromised patient, we mean that this patient's immunity is compromised and that the incidence of post-operative complications, including the post-operative infections, is very high. So this is very important. The second is the diminished bone stock after debridement. An integral part of the surgical procedure in spinal tuberculosis management is the debridement, the thorough debridement, the generous debridement. And this debridement is usually left us with diminished bone stock, which represents a problem in reconstruction of the spine. The third is the neurological deficit. We have to decompress the neural element, very important, or else the neural element decompression will give rise to neurological deficit. And lastly, we have to fight against the occurrence of the deformity or correct an already present deformity. So these are the four challenges which are faced with or met with in the management of spinal tuberculosis. The fact that we are treating an immunocompromised patient, the presence of diminished bone stock after debridement, the presence of neurological deficit, and the deformity. In 1952, Bosworth published the streptomycin use in tuberculous chemotherapy. And since the use of this streptomycin in tuberculous chemotherapy, the mortality rate drops by 72% within 5 years, and 2 years later, Bosworth et al. Reported on the use of isoniazid as a combined with streptomycin for the tuberculous chemotherapy. Actually, we owe the Bosworth and et al. All the advent in the surgery for the tuberculous infection of the spine, because without this chemotherapy, no surgery could have ever been done. We know very well that all the patients who have been operated with tuberculous infection, who have been operated on before the chemotherapy, usually they die because of systemic or metastatic spread of the infection, what we call the miliary tuberculosis, which is fatal. The incidence of miliary tuberculosis and the mortality rate dropped very much following the advent of the chemotherapy. It's very important to remember the great man of Professor Hussein Kamal Hassab of Alexandria, who was the first to work on the surgical management of tuberculous infection of the spine. Professor Lotfi Al-Adwar, the father of orthopedic surgery in Alexandria, actually his doctor thesis was about the surgical treatment of tuberculosis of the bones and joint with focus on Pott's disease of the spine. And as we can see, this thesis was submitted to discussion in 1964, which means that our department has a very long history and experience in the management of tuberculosis of the spine. Of course, the techniques of management of tuberculosis of the spine have changed a lot since that time, and to summarize the changes that occur or the advent that has happened in the management of tuberculous infection of the spine, I present this case. This is a 40-year-old male who is actually drug addict. He is HCV positive, which means that his immunity is questionable. He has a history of back pain for 3 months, and he is both generally free and he is neurologically intact. On doing the X-ray, as we can see in his plain X-ray, there is destruction of T12, of the body of T12 is completely destroyed, and we can see that there is a deformity, kyphus deformity, what we call small angular kyphosis, or what we call the gibbous, which is characteristic of tuberculous infection of the spine. As we in the CT, as we can see, shows the destruction, complete destruction of T12. Also, the destruction has started to involve the anterior part of the body of T11, as we can see in this CT scan section, the axial and the coronal cut, the sagittal and axial cuts, sorry. And we can see here in the MRI that T12 has been completely destroyed, and there is a sort of collection or an abscess which is encroaching on the spinal element. We have to remember again an anatomical fact that the spinal canal diameter is narrowest at the area of the dorsolateral spine, and therefore, in spite of the fact that this patient is neurologically intact, yet he is potentially liable to develop neurological deficit. Having seen all the CT and MRI of this patient, we have to remember one rule or one fact which is very important. The rule is multiplicity of the infection foci in tuberculous spine, especially nowadays when we are confronted with immunocompromised patients. So very important whenever we have patient presented with an infection in the spine that we should X-ray the whole spine looking for other foci of infection, and that's what happened actually. So in this patient we had another X-rays, CT and MRI of the cervical spine, and what was found is that there is complete destruction of the body of C5 and starting destruction of C6 by the infection, which means that there is another infection focus which is present in the cervical spine. MRI shows the story that the disc of C5, C6 has been completely destroyed. The destruction involves the bodies of C5 and C6. There is starting pus or cold abscess or caseative material collecting, and it is compressing or starting to compress the neural element in the cervical spine. So if we now consider the risk which of to start with, we decided to start with the cervical spine. So what we did was to do a thorough debridement of the destroyed bodies of C5 and C6, and this was done by what we call corpectomy, which means the excision. Excision means they excise all the diseased bone, all the sequestrated and necrosed bone, until we reach a fresh bleeding surface. So after corpectomy, we are left with a very large defect, and this defect, as we can see, has been compensated by the use of the Harms mesh. The Harms mesh is filled with fresh corticocancellous graft from the iliac crest and is placed to correct for this defect, to prevent collapse. And then because of the large length of the Harms mesh, we put an extra plate. As we can see, the plate is fixed in C4 and C7. Also, as we can see in the X-ray on your left hand side, we augmented this anterior construct with lateral mass screws. The lateral mass screws represent an excellent posterior reconstruct which will support the anterior construct and prevent the collapse. Remember that we have another focus, tuberculous focus, in this patient in T12 and T11. So we take the patient again to OR 2 weeks later, and then we did a thorough debridement and did the first stage of this surgery, which was posterior instrumentation, long segment, as we can see through transpedicular screws. And as we can see here that there is no gibbous anymore, the spine is straight, the deformity has been corrected, the infection has been debrided, and this patient has to go through another stage, which is anterior corpectomy and anterior reconstruction of T11 and T12 and the use of the same Harms mesh, the same we did for the cervical spine. So actually this case summarizes the advent in the surgical treatment of tuberculous infection of the spine. So to complete the program, before the surgery or before operating on tuberculous infection of the spine, we have to remember that the patient is immunocompromised, and we have to go through a thorough correction of the general condition of the patient. We have to put this patient on effective anti-tuberculous chemotherapy, and by effective anti-tuberculous chemotherapy, which the patient should have, we mean anti-tuberculous chemotherapy effective against this microorganism strain, as evidenced by decrease in the pain, decrease in the constitutional manifestations, decrease in the ESR and C-reactive protein, and correction of the disturbed CBC or blood picture. And after, we have to follow up and continue the chemotherapy for at least 1 year. So we have to continue the chemotherapy for at least 1 year. This is very important to prevent recurrence. The golden rules in the surgical management can be summarized in the following. First, care of the general condition. Always remember that this patient is immunocompromised. And by immunocompromised patient, we mean that this patient is very liable to develop post-operative complications, including wound infection or surgical site infection. So the immunity of the patient should be raised by fresh blood transfusion, by diet, by instructions to the patient, drained very well. Third, the thorough debridement. And by thorough debridement of the septic granulation tissue, we mean that all the necrotic tissue should be removed. All the necrotic soft tissue, all the sequestrated bone are removed until there is fresh bleeding surface of the bone. Because without this, we will not be sure that the effective anti-tuberculous chemotherapy will reach the site of the infection or the infection bed and the infection could recur again. So very important that the end point of the debridement should be the occurrence or the presence of fresh bleeding surface of the bone and soft tissue. Also, the decompression of the neural elements. Decompression of the neural elements should be done regardless of the preoperative neurological deficit. So this is very important. The neural elements, sometimes the patient is presented without any neurological deficit, but we can see that there is pus or there is some septic granulation tissue or tuberculous granuloma compressing the neural element. The neural element should be decompressed regardless of the neurological status of the patient preoperative, because potentially this patient could develop neurological deficit in the immediate postoperative period. Also, the use of a strut graft alone to prevent or correct a deformity is not valid anymore. It is not accepted anymore to put a strut graft like a rib or corticocancellous tricortical graft in order to correct and prevent the deformity. We should not depend on the graft alone. So what we should do is the use of telescoping cages or harness mesh. The harness mesh is a very good choice. It is very safe and very effective, filled with corticocancellous bone graft. The price is reasonable. The telescoping cage is a very good option. As we can see the telescoping cage, we can see that the telescoping cage can be adjusted. So the height of the cage is always increasing and adjusted according to the need to correct the deformity and to obtain the profile, the sagittal profile proper for the patient. Maybe the only disadvantage in my mind of the telescoping cage is the price, because it is very expensive. But otherwise, the telescoping cage represents a very good and the practical option for the correction and maintenance of the correction of the deformity. Also, anterior construct alone is not enough to prevent the deformity or collapse of the spine, and long segment posterior fixation is mandatory. This is very important, which we should remember all the time, that if we correct the gibbous deformity and we put the anterior construct by harness mesh or by telescoping cage with bone graft, this should be augmented and supported with long segment posterior fixation, whether in the cervical, in the dorsal, or in the lumbar spine. In the cervical spine, the posterior augmentation can be done by the lateral mass screws. Actually, the lateral mass screws in the cervical spine, this construct represents an excellent posterior augmentation, which can be very helpful to prevent any failure in anterior construct if it is left alone. Again, in the dorsal and the lumbar spine, this posterior augmentation of the anterior construct is provided or achieved through the transpedicular screws. So the transpedicular screws in the dorsal spine and in the lumbar spine, sacral spine, they represent good augmentation to the anterior construct. Again, the combined and the posterior instrumentation allows the early ambulation of the patient, provided his neurological status allowed and usually without bracing. And this is a very good advantage, because we allow an immediate post-operative rehabilitation of the patient if his neurological status allows, without the use of any bracing, provided that the anterior construct is augmented by posterior construct as well. Again, the posterior spine fusion alone does not control the progressive kyphosis, and this message is actually delivered by many papers and through many conferences. The anterior fusion is mandatory, so all the time we have to insist on both anterior and posterior construct in order to prevent the occurrence of the recurrence of the progressive or the progress of the kyphosis deformity. Lastly, the intervention radiology could be helpful in drainage of the large abscess when the patient is unfit for major surgery. And this option actually is very helpful because many of the times the general condition of the patient will not allow us to take the patient to OR. So instead, we can refer this patient to one of our colleagues in intervention radiologists who can actually drain the large cold abscesses, decompress the neural elements as a compromise until the general condition of the patient allows to take him to OR in order to correct for the major or the definitive surgery. So these are actually the main points which summarize the large advent in the techniques of the surgical treatment of tuberculous infection of the spine. I thank very much Adwia company for their support, for giving me the chance to contact you about problem. And I will leave here my email. This is Raafat_Ragab@hotmail.com. So if you have any questions, please don't hesitate to send these questions. I will try to respond as soon as possible. And thank you.